brief introduction, and then I can take over and walk through the orientation of the program.
Yeah. Thank you so much, Dr. Ashwath. And thank you for all the panelists for joining us today. Today, we'll be talking about decoding patient billing and claim life cycles. So this topic is interesting to us because of the fundamental changes that are coming in into the insurance segment with government-funded schemes like Ayushman Bharat that are going to define how healthcare operations take place going forward. Specifically, we'll be talking about complexities of billing in healthcare for government-funded and private health insurance schemes, claim submission challenges, claim processing time at provider end, resulting in accumulation of account receivables, role of healthcare IT in streamlining these processes. Like I said before, we have an audience of students, of doctors, of practitioners from the industry, and we have a very esteemed panel. To moderate the discussion, I would like to pass on the floor to Dr. Ashwath, who will be talking throughout the webinar, will be arranging all the important points, and will be expanding on the topics that have just been discussed. So thank you everybody for joining, and Dr. Ashwath, please take the floor.
Thank you. Am I audible?
Yep.
Fantastic. So thank you, ladies and gentlemen, for joining this afternoon, Saturday afternoon, for this discussion initiated by M16 Labs. I'm one of the team members at M16 Labs, but myself, I'm Dr. Ashwath Vinayak Kulkarni. I'm a dental surgeon by profession. I took a lot of interest in healthcare operations and hospital operations and how to solve complex problems at the crossroads of healthcare, business, and technology. And we connected with the M16 team, and we are trying to dig into the details of what are the real world problems executives and top management and doctors and nurses face in hospitals, and to understand more about one of the verticals, that is the accounts receivables and claims processing, insurance claims processing. We have here three of our esteemed guest speakers and panelists. To start with, Dr. Santanu Chattopadhyay, he's the cluster head of Roche, and he's a family physician, and he holds master degree in internal medicine from PGIME or Chandigarh, and his career spans over 2 decades. And he's been brain behind many of the startups in India, including Nationwide. And we have Mr. Prashun Chatterjee, who is the CEO of Nemcare Hospital, Assam. He's a engineer by profession, and with a postgraduate from Indian Institute of Management, Kolkata, and has about 25 plus years of experience in sales, marketing, and brand management operations, so on and so forth. And he has worked in GE Medical Systems, and he's been in Canada as well, and he's worked in Manipal hospitals and several other hospitals in Kolkata and eastern part of Canada. Soon we'll be joined with Dr. Paramahans Mishra, the COO of IQ City Medical College and Hospital. He's an MBBS graduate, and he's done a lot of work in hospital and healthcare management. And I'll give a brief orientation towards the topic. We most of the hospitals, if you broadly categorize it, the credit payment categories in a hospital could be broadly divided into 3 categories. One is the insurance. Bills are typically settled by third-party administrators. The average payment cycle is anywhere between 30 days to 45 days. There are public sector insurance companies, there are private sector insurance companies. Second is the direct public sector payments, empanelments or corporate empanelment, like CGHS and so many other schemes which have government published rates. bills are settled directly by the corporates, and the average payment cycle is 45 to 60 days. And government schemes such as the central schemes and Ayushman Bharat schemes have their own cycles. And, one of the key problems, most of the hospitals, even while I was managing one of the hospital operations in one of the small hospitals, was the tracking of these billing cycles and many of the administrative mistakes. The key idea is to dig into the current scenario of these three categories, and which contribute to nearly 55 to 60% of the total number of patients in a hospital, right? So, of course, it can vary according to the hospital business model, but billing mistakes can lead to a lot of queries, a lot of need more infos, requests, and so on and so forth, which delay the payment unnecessarily. And this adds to the months to the claim's life cycle and affecting the cash flow of the hospital. So understanding and identifying the what contributes to this claim problems is the core idea of this meeting. I pass on the platform to our first speaker, Mr. Prashun Chatterjee. Sir, please go ahead, and we'll be happy to hear out what the real world problems you guys face.
Yeah, thank you very much. And thanks a ton for inviting me here to express my views on this particular topic, which is a very, very perennial and a very painful thing for all hospitals in terms of the cash flow management. The credit bills pile on, and there are numerous reasons why the credit settlement gets delayed. Okay. So let me first start with from where the delay starts. The delay starts is once the patient, a credit patient, gets admitted. The first thing is to get the approval of the credit patient for a cashless service. So that is managed by a TPA. Usually, it's a TPA of the insurance company who manages that. And again, there may be approvals, but there may be conditional approvals. Okay, but we go ahead with that, and then the patient is treated. While the patient is being treated, the doctor is treating them. Doesn't treat them separately from a cash patient and a credit patient. So that's the first point of differentiation, which is usually cannot be done, but it happens because the rates are different for a cash patient and a credit patient. Because for a credit patient, it's a signed MOU with special rates. So that's the first kind of discrepancy starts seeping into the billing system. Okay, once the treatment is done, again there is a huge documentation part at the end of the treatment to be completed, compiled, and sent for the claim. Okay, now that is where all the problem comes. The claim settlement of submission is the first or the biggest pitfall for the delay. How I'm telling you, how I'll explain you. See, I have divided this into three parts. The first part is the financials, the rates. There's a huge mismatch between the rates, what have been, what has come into the billing system, and the agreed rate with the TPA or during the MOU sign-up period. So the people who are working on the billing section, it's very cumbersome for them to see every bill to match it until and unless it is systemized. So there where IT plays a very, very important role, where all the pre-MOUs and pre-conditions between one TPA and the hospital has to be recorded. Again, it's a data entry problem from the hospital side. It's an approval problem from the hospital side. Why this doesn't happen very quickly? But that is where there is a huge lacuna between different hospitals. So that is where people need to understand there's a huge difference between the agreed rates and the rates that comes out in the final billing. Okay, so that's the first point. The second point is the format of the bill. Different TPAs, different corporate requires the bill in their own format for the claim to be submitted. Now this format of the bill is very important for the empanelment section or the credit billing section to understand what format billing has to be done, or the bill has to be prepared under what format for the particular TP or for the particular corporate to be satisfied for the claim settlement. So that is the second biggest point which needs addressing from the hospital's point of view. The third point is which is the most cumbersome process is the attachments that is required for approving a particular bill. There are numerous attachments. Like I'll give you some running example, like the problem that occurs in my hospital. A patient comes in, a doctor asks for ECG, in the ICU. The ECG person goes and takes an ECG and says the ECG reports are perfect, fine. The doctor starts the treatment. Now this ECG, when you are billing it to the credit patient, now doctor doesn't see whether it's a credit patient or a cash patient. Okay, he just sees the ECG and the bill comes in the system. The system, when it goes to, there is no report generated because the doctor has seen the ECG result and taken a decision and have done the corrective measures for while treatment. But when this particular ECG bill is going into the bill without an ECG report, the bill gets bounced back, saying that the ECG report was missing. So for a small amount, like which is something 100 or 150 rupees ECG report, a lakh of rupees bill gets stuck. So this is one. So the attachments, what is going with the bill has to be exactly in the prescribed form of what is required by the TPA or the corporate. So these are the three areas. If the hospital can work and automate this through IT, I think 80% of the problems can be solved. 80% of the problems can be solved. The next thing is bill submission. Okay, once the bill is submitted, you don't know whether the bill is going to get bounced back or it is going to get paid. Just a second. The bill is going to break because the claim settlement can get stopped because of various queries. Okay, now the queries are addressed. Again, it goes to the claim settlement department, and that time maybe the bill gets settled. Now, usually, what I practice in my hospitals is we take the billing cycle into 30, 60, and 90 days bills. 30 day, if the bill is getting settled within 30 days, that means there is no problem. If the bill is not settled within 30 days and it has moved into the 30 to 60 bracket, then it's a problem that a query has been raised and we haven't addressed that query. Okay, and if it moves beyond the 60 days limit, then there is a problem with the addressing of the query. Like maybe we don't have the document or we don't have the right approval before doing the particular treatment. So there can be various problems for which the claim will not get settled and get bounced back. So that is where we need to have a check, like have a strategy for bucketing the pending payments into 3 different buckets, like 60 days, 30 days, 60 days, and 90 days, and have different strategies to check out how these bills can be, the payment can be realized for this particular bills.
So
this
systematic tracking is required.
Systematic tracking is required after the bill submission. Okay.
Correct. And most of the times when they come back, many other questions asking for more information or something, it should have some sort of a tracking mechanism to update those things.
Absolutely, absolutely. So those are something very, very essential for any hospital to be successful. The third part of this particular whole thing is, like once the claim has been settled, there are certain amounts which are not disallowed. Okay. Now, this particular settlement, when it comes, it has to be settled in our system, okay, with discounting the portion that has not been allowed. Otherwise, if you don't discount it, they get accumulated and show in the system as a huge pending payment, which is never going to come.
Correct.
Okay.
And, sorry to
so this management is very important. Like part A is the claim submission. Okay. In claim submission, as I told, there are 3 parts to be very well managed. That's the pricing part. The second is the format part, and third is the attachment part. Once this particular things have been met and the bill has been submitted, the bill payment cycle has to be measured to understand where the bill cycle has been stuck up, so that you can have strategies for different things. Once the realization comes, then you have to correct in your system so that the balance, what is pending, I have raised a bill of 1 lakh rupees, but there is only 60,000 allowed. So this 40,000 needs to be discounted in my system. Okay, otherwise this gets reflected as a pending payment or a receivable in my book of accounts.
Correct. So once that problem we have identified and we are able to track it and we are able to manage it, next comes the reconciliation part, right? So Dr. Santanu, would you like to share your thoughts, your experiences, reconciliation matters, NMIs, and so on and so forth?
Yeah, so I think Mr. Chatterjee is very well covered. Just give me 1 minute. Huh?
Sure.
This is a problem with working from home. Yeah, so
that's all right.
Yeah, so what I was saying, Mr. Chatterjee has really explained it very nicely, particularly the issue he picked up with the ECG. Let me tell you, I am the sufferer. I used to head Birla Hospital a couple of years ago. I ran that place for a good couple of years. And we had an account receivable of to the tune of around 2 times of my annual EBITDA. So put it this way, that if you close down the hospital for 2 years, if I get that money back, I will still arrive. So that is the extent of the problem. Okay. So when I took over, I was told that this is what we have to clear. And your immediate thought is, okay, these people whom you are supposed to get money, they are not paying, right? So you will talk to your people and say, yes, sir, I was going there, waiting there for hours, nobody, they say they are not paying. So it's like, it sounds like a bad debt, but when it started getting into this is exactly what Mr. Chatterjee highlighted. The issues are at 3-4 level. One is the rate reconciliation. The second one, what he mentioned, is that giving in the format. Third is that the attachment, etc. So what you will have to understand that as it goes now to the thing, there are 2 kind of things, right? One is an administrative thing, that have you actually given in this format? Have you actually given this attachment? So this is one part. The other part is genuine medical query. Why did you do a CT scan in this case? Just because doctor felt that it is right, insurance company has right not to authorize it, because we are supposed to do protocol driven care. We are not in 1960s or 70s where doctor knows best and we do. We are supposed to follow protocol driven care. So if I am done a CT scan, let's say twice on a patient, if I done a COVID, let's say, one for diagnosis and one for prognosis, may not be, yeah. So just an example, I didn't mean to that whether you should do it. So I think that is one kind of a query, because on the other side, on the insurance side or the corporate sides or a government insurance side, there are certain medical professionals who will typically raise the query. So this bunch of queries now come to the hospital. Now hospital needs to now track these queries into two streams. One is more related to billing and administrative, other is more medical. And I have seen that this is typically sits there, billing guys does not know how to answer clinical, and there is not a coordination. He just keeps on sitting, sir, payment nahi kar raha hai. Then he goes and tell, again the collection guy goes, make another trip without solving those problems, So what we found, what we did is that exactly we found that this is where a lot of things are stuck in our experience. One is obviously not submitting, but even after submitting or sometimes because of not submitting properly, these are the type of queries that are raised. Now these queries now need to be resolved and gone back, right? And there may be a further query on one this thing. So this needs to be a very nice tracking mechanism. And as a billing head or maybe hospital head, I should be able to see it, where it is. Is it the first query, second query, third query? Who is supposed to respond? Is it the medical guy who is supposed to respond? Is it the billing person who is supposed to respond on their side or our side? So all these things. And another very funny thing that is to happen, which is sometimes they will say,
Hi, good afternoon.
Good afternoon.
Hi, Dr. Mishra. Good afternoon. Sorry, I think Dr. Santanu was just in the middle of his thoughts. Sorry about that.
So, so another funny thing used to happen is that they will say that we have settled the bill, and then we realize there is a lump sum payment that has come. Unfortunately, that is not, Doctor. Suppose I have an outstanding of 10 crore. Suddenly, I get 1 crore credit. Yeah, but I do not know where to put this. So that was another. This is where the reconciliations come. Like for which bill, how much have we got? So I think if you try to do this for as I said, this was a 200-bed hospital. It's a manually managing this is impossible. I mean, it's not, even if you put 100 people, I don't think it is going to solve. Yeah. So what I realized at that point in time, this is back in 2016, I used to think that if you can put technology around it, can we track the whole thing, that how it is moving and how we can tag it? And then I was very pleased to hear when Anil got in touch with me with their solutions. And I said, wow, this is what I was looking for, right? This is exactly what the doctor ordered. So I think this is a real genuine problem. And let me tell you, as I said that before, I was not experienced. There is a general black box that people are not ready to pay you. It's not that. There is a lot more to it. And the genuine, I mean, the one which really doesn't want to pay you, that's a very different thing. That's a collection issue. That is not necessarily a receivable issue. Yeah. So I think technology solution is paramount. And as I say that I have felt that solution is required from the user point of view. And this is where I give a credit and thumbs up to the company, because I've been in healthcare startup for last 15 years. And a lot of time I find technology people who are coming not from healthcare come up already a solution and then try to fit and find where is the problem. And I said, I always tell them that you already found a solution, now you're trying to fit it. Yeah? Hit and miss. But I think what I give credit to MetahOS is that they have say, okay, this is the problem and I create a solution. So starting from the lock and creating a key, not creating a key first and then finding a lock.
That's a very nice way to put it.
Yeah, so that's what my submission to the panel.
Thank you very much for your comments, Dr. Santanu. And we are also joined by Dr. Mishra here. He's the COO of IQ City Medical College and Hospital. Dr. Mishra, your thoughts about the billing claims and reconciliation and all the backlog of these claims accumulating. Any comments about the patient journey? How we need to understand this problem better so that we can break it down and provide better solutions.
Yeah, thank you, Ashwath. Thank you, everybody. Sorry, I got little held up, delayed. Billing is one of the most important aspects of any profession or any business. If you don't get the money what you have served for, so there's the whole scenario or whole workout goes waste, and it is one of the most painful part of a medical care.
Yeah.
Everybody comes, every day we face daily situation that patient comes in a very serious situation, and then they say that you do whatever you want to do, take whatever money you want to take, but save the life of the patient. And as the treatment goes, as the patient improves or not improves, when it comes to payment, that is the most sore point for patients and for staff also, because those who go to collect money get lots of accusations, lots of abuses, and those who come to make payment, they show a surprised face that, oh, bill itna kaise ho gaya, hamara to itna treatment hi nahi hua. Nowadays, the cost of any good ICU care in first day is around 40 to 50,000. Any good ICU, because lots of investigations are done, lots of initial treatments are done, many procedures are done. Patients are not willing to accept that the cost of treatment has gone high. So that is one very important. That is one very important thing. We need to counsel patients at the time of admission. But medical profession is very strange in this way that even if patient does not have money to pay, or even if they do not pay, and you do not provide them the services, you are accused of neglecting life by public, police, court, media, everybody. That, oh, you are giving importance to money rather than the life. Nobody understands this, that the private healthcare also comes with money. Nobody is going to serve you free of cost. And no consumables, no doctor comes to serve free nowadays. It's not a government hospital where they are paid by the government. Supplies are made by government. It's a private healthcare. So what is important is the counseling of patient and relatives at the time of admission. Maybe you may not tell the exact or total treatment cost, because that may upset the patient, and patients say that no, we will take our patient to some other hospital, you are very costly. But you have to brief them that this is the initial cost, and depending on the course of patient improvement, the cost may go high. That, and it has to be taken in writing with them. Otherwise, they deny that I was not told, I was not counseled about. And
hello.
Second,
good afternoon, sir.
right. So second thing is the regular recovery, regular system to get money. That is important. If you tell anybody at the end of the treatment that you have to pay 5 lakhs rupees, nobody will be ready to accept, and then they will create or make lots of that
which Anish has forwarded to me today.
this is not fair, this is not right. So regular recovery is very, very important. And for that, I have employed in many hospitals one person who is doing this job only. He comes in the morning, takes the list of the dues, goes around the patients, and get the bills signed by the people, explains them, and recovers as much money as possible. So that has reduced the bad debts in many ways. And people are routinely counseled also that this is their bill and this is what has to be done. That person, if he's good enough, he's worth the money what you pay him. Because there are healthcare, there are lots of people who go away without paying, and you cannot do anything. Court says that you can file a civil suit for recovery, but nothing happens ultimately. Court and police and everybody, media, everybody is in favor of public against the medicos and doctors mostly. Hospitals also.
Yeah,
Then,
yeah, sorry, go ahead, sir.
Then there is a tracking system in the dashboard that I keep on seeing the patient's bills. It is daily monitoring. The administrators, GM operations see, and we keep on priming our doctors also that this patient's bill is this much, he is not able to pay or he is not ready to pay. So please take care. Don't do costly procedures, don't do costly investigations, do only what is minimum is required, so that the doctors are also primed, mentally prepared, means where to be very aggressive, where to go a little slow. That is also important.
And Dr. Mishra, and of course, other panelists as well, what we have already is we have kind of covered about the cash payments, we have covered about insurance, third parties, tracking the system, reconciliation, how we can, make sure the user interface is better to upload all the documents on the go, all the reports on the go. What is your experiences dealing with the government schemes? Because there I feel that many of the reconciliations and account receivables get dropped out in that 90-day cycle. That's what especially when we are doing things manually. Any comments on that?
Yeah, I was coming to that. I was talking about cash payment. Now, if we come to the government schemes and come to TPAs and all, you have to have a separate desk and a dedicated person checks all the bills, all the documents before it is uploaded on the, because once you upload something, previously it used to be, hard copies. So once it is gone, you couldn't do much. Now most of the things are on the website, on the, they are uploaded on the site. So once some documents goes, they will treat it as per the document. You cannot make any changes. If you change something, they will feel that you are trying to manipulate something. There may be supplementary answers, there may be supplementary papers, but you cannot change what you have sent. So that is very important. But besides, even after sending the documents, everything all right, these payments keeps on, getting piled up in CGHS, ECHS, ESI. In Bengal, we have Swasthya Sati. Other all over India, there is Ayushman Bharat. They will take many excuses that we don't have money, we don't have budget. There is this problem in your document, this thing there. Then there are lots of underhand payments asked for. All these issues are there, and we have to really struggle with all these.
Dr. Ashwa,
go ahead.
Sorry, we have a question from the audience.
Sure.
You want to take it up by Mr. Sriraman?
Yeah, I was just coming to that. You can read it out, Arnav, please.
Okay. Yeah, well, Mr. Sriraman is asking a layman question. He wants to know the TPAs usually pre-authorize the claims. What does that signify? Where will there be disallowance later, except for issues like wrong format, inadequate supporting, and such technical reasons? So given all of your practical experiences, sir, perhaps we can ask Dr. Santanu if he would like to elaborate on this.
Yeah, I think, see what pre-authorize means. Let's take a case. Let's say a gallbladder. You say there is a gallbladder, you inform the insurance and he says, yes, it is a gallbladder case, and they check, okay, you do not have this gallbladder issue at the time of when you started the insurance, it is pre-authorized. But what it still means that you will have to submit the thing in proper format, the supporting, why gallbladder was done, what was the post-operative recovery, if you have given some extra antibiotic apart from what you normally give, why did you give, any ultrasound, etc. So what pre-authorization means, as in principle, that is approved. They will not deny that. They will not be like suddenly they cannot change. No, we will not cover gallbladder in the insurance. Or you had this disease before, and we suspect will not. So that will not happen. But it is still subject to providing all the supporting document in the right format and the right rate. So that's what it means, pre-authorization.
Fantastic.
Thank you.
And
Dr. Ashwat, there's another question from the audience.
Sure, go ahead. Before I ask another question, you can go ahead, please.
Okay, perhaps Dr. Mishra can answer this.
Yeah.
How do you find out if a claim has been partially paid? Does ESI tell which service item has been approved and which service item has been rejected?
That's a very serious issue with many government organizations because they pay in a lump sum amount. CGHS, ECHS, ESI, they pay in a lump sum that they will pay, suppose your claim is of 2 crores, they will pay you 50 lakh rupees. Now they will not tell details, which case, which service they have paid for, which you have to personally interact with them and find out the details, which case they have paid and what all services they have paid for, what they have denied for. So that's a very tricky issue, but getting money from ESI is itself a big boon. So you forget about the reconciliation. You just have to be content with that. Okay, your claim is 52 crores and you've got 50 lakhs. That's the situation.
Wow. And Mr. Chatterjee, perhaps you could take this question. I have a question asking about permissions of high value procedures and emergency procedures, etc. What kind of challenges do you face in terms of documentation? Because you already explained about the ECG example, right? So how can we ensure that we can make it more user friendly, the systems and the process?
See, getting the permission for high value treatment or procedure is a little bit of challenging thing. Okay, it all depends. Usually for any cardiac case, everybody goes on a package system. They don't allow you to do anything and everything for a particular cardiac patient. But you have to be within the package limits of the package. So there are certain things allowed within the package, and you have to be within that. If there is any treatment done apart from those things, like a cardiac patient may need some other support, maybe some kidney issues or some other issues. So that is treated totally differently, separately. You need to get a separate claim for that, or separate this thing for that, or you need to counsel the patient party that this is what has come up and it will be not covered by the insurance, and you may have to pay separately for this thing. So this kind of things keeps on happening. These are the challenges we have to face. Like when there is another complication which crops up within a particular package, Usually the high value treatments are always packaged, but the challenge is whenever there is a other thing crops up, then the challenges happens whether you need to take another approval from the insurance company, or you need to talk with the insured patient and get it settled in cash.
Yeah, Mr. Chatterjee, speaking of high value treatments, there's another question which has been asked by Mr. Aliket Siddharam about robotic surgeries.
Yeah, interesting.
to know whether these surgeries that are costly are approved by insurance companies.
Not yet.
No. Okay.
Wow.
And what do you see as the way forward for it?
See, the way forward is insurance company needs to find out that the robotic is the only way of treatment.
Right.
Okay, if there is any another cheaper way of treatment, then the insurance will not go for the costlier settlement.
Wow.
And
so how do we prove that? Like,
yeah, sorry,
But-
Dr. Ashwath, just to add to that question, there's another question from Mr. Santanu Pal, who wants to know that nowadays you have insurance companies that pay directly to the hospital.
yeah.
And many times patient name identity is also missing, which makes the reconciliation procedure almost impossible. So Dr. Mishra had briefly touched upon this topic before. So perhaps, if you don't mind, so taking us through your practical experience again, sir, how would you deal with these kind of reconciliation procedures?
In this kind of reconciliation process, you have to again go back to the payer and understand exactly what bill and what has been paid and what has been disallowed. You know, so this is a procedure we have to do it. But with everybody, like when they pay, they don't usually pay saying that they have settled this bill this much, this bill this much. They pay in lump sum. Then decoding that payment is a work of ours to go and decode like what has been paid, what has been disallowed.
Right. Thank you, sir.
And regarding government-sponsored patients, I have a question here. What are the challenges you face in terms of emergency admissions where the government is the payer? Any comments or thoughts on that?
We don't treat it very separately because see, the protocol is whenever a patient comes for emergency, is the right. Is the first thing is to stabilize the patient without seeing whether it's a government, private, a TPA, cash. Stabilization of the patient is the first and foremost. Then we take up the other necessary issues like how the payer is going to pay. Whether it's going to be settled in cash, it's covered by some government scheme, or it's covered by some. See, usually what happens, typically in a hospital, the patient gets admitted through two different doors. One is through the emergency, and one is a planned through OPD. Okay.
Yep.
So when it comes planned through OPD, there is a lot of planning what can go on because the patient can wait. It's more of a planned treatment rather than an emergency treatment. But in an emergency treatment, it becomes little cumbersome. First, we need to stabilize the patient and then see how the payer is going to pay.
Right. Sir, on the topic of costs, we have another question from Mr. Yash Jain. I think he is also a student of IIHMR. So Mr. Jain wants to know if hospital wants to install the operating system in their hospital. It will definitely increase the operating costs of the hospital. So how can hospitals cope up? Dr. Chattopadhyay, would you like to take this question on?
Sorry, can you say that again?
Okay, so if a hospital wants an operating system in their hospital, it will increase their operating costs.
Correct.
So how can hospital cope up is the question that Mr. Jain is asking from IIHMR.
Okay. I think, see, as simple, anything you do very fundamental is an investment or you can call it a cost or investment. So you have to see it that way. Like for, suppose, let's take it slightly differently as we are talking about robotic surgery. So there is a huge upfront cost to buy a robot. So there has to be a business case that how much revenue you will make from robotic surgery, and then how much will be the cost. Similarly, if I put an IT system in place, it will bring not revenue, but it will bring some operating efficiencies. For example, if we say, if I go back to my example of 200-bed hospital, which I was running, we have a bunch of people who will be uploading the bill, checking the bill, finding out how that will be. So there may be 4 or 5 people who is doing that. In spite of that, they are not able to get it right. The software may be able to make it right and then two things will happen. Probably from the 5 people, there will be requirement of 3 people. So you save the salary of 2 people. And secondly, the fact that you are not getting money on time, or sometimes, as Dr. Mishra said, not getting at all. So think about it. I mean, it's a very large sum of money. I gave you the idea. It's around 20 crore outstanding at that point of time. So think about 1% interest on 20 crore is 20 lakh. And how much are you spending on this software? Maybe 20,000 rupees. So I repeat, 20 crore was outstanding. So if you take 1% interest, that is the commercial interest, that is 20 lakh. And here, you, by paying 20,000 rupees, you might be able to bring down to 20 lakh to 10 lakh. So you still save 10 lakh. So basically, you have to create a business case. So whether it's a upside on revenue or cost reduction, anything you do in any business, when you are trying to do an investment, you figure out what will be the efficiency. Is it on the revenue side, cost side? What is, how much I'm extra spending from this, how much I'm saving or increasing, and there has to be a good. And as I said, there is a huge margin here, so you will not have to worry about that how much you will get. It's huge difference between 10 lakh and 20,000.
Yeah, it's actually the return on investment calculated on the cost of funding.
Cost of funding. Okay.
Every fund has got a cost. You know, so if the cost of fund is more than your investment, I think the investment is worthwhile.
Mm-hmm. And Dr. Mishra, perhaps you can take on another question which has been asked by Mr. Santanu Pal. He wants to know, does TPA or insurance company give any balance confirmation or ledger? Sir, I think you're on mute, sir.
Usually on their own, they don't give. You have to really follow up with them. And you know how much bills you have uploaded and what is the amount due. And you have to follow with them that how much is paid and what are the differences, how much is pending. From their side, they tell that we have paid you this much are disallowances, and they may, depending on their, how much efficient they are and how much transparent they are. But balances you have to calculate and you have to follow with them. Right. Most of the hospitals are forced to write off lots of bills, lots of amount after following up with them for 1 year, 2 years. They say that it's not worth chasing them. They are not going to pay. So it has to be.
Okay. Wow. It's unimaginable. Before the we are almost hitting the time. I think we have last couple of minutes. I think about 6 or 7 minutes. But one of the key questions, what I wanted to understand was, of course, there are billing challenges, operational challenges, and before the webinar began, myself and Mr. Prashun were discussing about the cultural issues about the hospital staff not open to transition from paper to tech. Any thoughts on that? How do we bridge that gap?
Well, this used to be true sometimes back, but now with the modern generation coming up, people are more tech savvy. Even a simple graduate is very well aware of computers and all. They know, they do some courses in computers, and they are well versed. I don't find it much of a challenge, except for some, maybe. Most of the people are well versed with it. They learn it. On the job training is of course important. They may not have really practiced it during their course or during their curriculum education, but they take it up. Only thing, the hospital has to take up this challenge to retire old hands who are not, willing to change. We have to take a call that people who are not willing to take it to change with the time, they have to be either adjusted somewhere or they have to be retired, because modern hospitals cannot run without these
technology.
Because every payer is now online. So you cannot be doing the same thing, making files and taking it to the CGHS or ECHS or ESI. Everything is online. You have to be online. That is important.
I have
Yeah,
something
go
to
ahead, sir.
say at this point. See, I think this is I will take a little bigger perspective. It's not only the billing, like challenge of adopting technology by all member of the hospitals, including doctors. So I would
Yeah,
divide into two parts. One is clinical and non-clinical. As Dr. Mishra was saying, there are a lot of clinical activity. Non-clinical, let's say, it is probably a relatively easier than doctors because many of time you can push it and thing. One piece of advice. See, today everybody has a mobile. Okay, so more and more you can actually do things in mobile. So the IT, this is an advice to the IT system people who create something which is mobile friendly, which I can do through my, it doesn't have to be an app. It could be a mobile adaptive technology, but everybody knows how to type in a mobile. So
yeah,
rather than system driven, if you can create a user interface for mobile first, that is the philosophy, rather than PC first. So move to mobile first concept. For clinicians, the issue is different. Whatever, even mobile, it takes up a lot of time to chat. And it's never like a WhatsApp chat that even at WhatsApp chat, it's longer to chat than to speak, right?
yeah,
And sometimes what people do these days in WhatsApp, they will record a conversation and send it because they don't want to write. So if
yeah,
you take a cue from that, I think we need to move to voice-based TMR, which is something like Alexa, where you will just give a plugin where you should give a command and then it should type. And the technology is now available. Already we see Alexa is doing it for general, but I think we need to have medical specialists Alexa. Ashrat, you work in Canada, I used to work in UK. We used to
yeah,
have secretaries where we give the dictaphone and they type. So we should now have virtual secretaries who will type it for you
yeah.
and who will also understand your accent, will understand the language you're speaking. He knows what's it. So I think that's already incoming. I know several companies are trying to crack it, and I see this happening coming very soon, within few months or to a year.
No,
We
that's
are working towards that.
yeah.
Uh,
And Dr. Ashwat, sorry, I mean, since we're so
yeah,
short on time and there are a few questions remaining,
sure.
I just take one last question from Chetan, who wants to know, should hospitals stop doing government schemes if their account receivables are pending? So, Mr. Chatterjee, if we can ask this question to you based on all of your experience, what would be?
I will tell you, we are very selective about governments. Okay, I'll be very, very frank with you because whenever we run a hospital, the first and foremost thing is to fill up the hospital with maximum capacity. Okay, so if I'm suppose running a 200-bedded hospital, so first I will see to fill up 80% occupancy. Okay, so that time, strategically, what we would like to do is that time we will definitely encourage the patients from anywhere and everywhere. Okay, but once that is achieved, then strategically we work on the average revenue per patient, and average revenue per patient is more for other cases other than government. So usually the private hospital shifts away from the government once the hospital has picked up doing the business. That's what the trend is all over India.
And the claim settlement. I know we are running out of time, but last one or two questions, if I may, before we jump onto the vote of thanks. Here in the comment section, I hear, IRDA. Can't we take up issues with the IRDA for claim settlements? Who is paying cash more or credit more? Generally, in the eastern parts.
I don't think so. IRDA will be of any help for claim settlement. IRDA is a different. It's a body which fixes up the rules and regulations of insurance. It doesn't do anything with the financial claim settlement and everything.
Fantastic. So before I pass on the stage to my colleague Santanu Sarkar, I would just like to quickly summarize the learnings what I took. One is improve the user interface, improve the time spent on typing and recording, improve the tracking mechanisms within the system, make it more adaptable, try to make it more friendly in terms of bridging across other existing platforms and accounting systems or HIS or EMR systems. And of course, when we talk about adaptability, we need to make it more user-friendly. So these are the key points I took from this discussion. I'd like to thank all the gentlemen, and Mr. Sarkar, you can give your closing comments.
Thank you, Dr. Ashwath. Good evening, ladies and gentlemen. My name is Santanu Sarkar. It gives me immense pleasure to deliver the vote of thanks for this webinar. I would like to thank Dr. Param Mishra for his insights on the importance of documentation and correct documentation for each patient, which contributes to incorrect billing and delays in bill submission. A very big thanks to Mr. Prashun P. Chatterjee for sharing his highlights and challenges faced by him in his hospitals in various departments, which again contributes to need more infos. We are really grateful to Dr. Santanu Chattopadhyay for taking out time to join this discussion and sharing his vast knowledge on hospital admin and healthcare IT. I would also like to thank all the attendees for being such a wonderful audience. Thank you, ladies and gentlemen. And we end this webinar here. And we also want you to attend our future webinars. We will be getting in touch with you for our future events. Thank you.
Thank you, ladies and gentlemen, and thank you to the panelists. Fantastic, thought-provoking discussion.
Thank you.
I'm sure we will take your inputs and develop better systems.
Thank you very much, everybody. Nice to talk to you. Nice to interact.
Thank you, sir.
Thank you,
Good
sir.
to talk to you, Dr. Mishra.
Thank you.
Thank you, Dr. Chattopadhyay. Thank you, Mr. Chatterjee.
Thank you.
Thank you, guys.
Thank you.
Bye.
Bye.